This is Dr. Corey Maas on Looking Your Best, and I'm very honored to have Dr. Craig Nielsen, who's the director of the San Francisco Rejuvenation Center, the San Francisco Surgery Center, in the building that our offices are located, as well as other physicians. The San Francisco Rejuvenation Center was established in 2009, so it's been in operation for almost 7 years now. And Dr. Nielsen's been the lead of it. He's a board-certified anesthesiologist, a graduate of USC Medical School and residency training in anesthesia. He's been in practice for 30 years in the Bay Area, and really has focused his anesthesia practice, along with those members of his team that are part of the anesthesia department that he runs, on plastic and aesthetic surgery specifically, which has its own nuances and special things to do, which we'll talk a little bit about. So Dr. Nielsen, welcome. Thank you for taking the time to talk to us. A few of the questions that I think a lot of patients have for us as surgeons, and I'm sure you encounter them when you talk to our patients, are about how much anesthesia has changed over the last 20 years, 10. I mean, even in the last few years, there's been big changes in sort of types of anesthesia, the medicines, the monitoring, and all that. And I wondered if you could comment on that. What changes you've seen? Has it improved comfort and safety, the main goals of anesthesia?
Yeah, absolutely. Certainly, one of the main things is just the monitors. A lot more safety built into the monitors. We have pulse oximeters on all the patients, so I'm getting beat-to-beat measurements of their oxygen content in their blood. We also measure the amount of gases that they get, so we know exactly how deep they are. Some of the other things that have changed dramatically is just the anesthetic agents that we have are much shorter acting. So patients, you don't have the long groggy periods that you used to have, where patients are sleepy for hours afterward, less nausea and vomiting with the agents we use. So I think those are kind of, patient comfort and patient safety have dramatically improved over the last 10 to 20 years.
And we talk very often with, patients ask about anesthesia, and I think everybody watches 60 Minutes, so they get a sense of, God, these are horror stories. But on a relative scale, with the newer technology and techniques and that we have at the San Francisco Rejuvenation Center, most accredited facilities have, the safety, can you give us some perspective on a sort of relative risk scale? I mean, we all take risks.
Sure. Well, as I always tell the patients, the most dangerous part is driving to the surgery center.
Right.
I think you can kind of put that in perspective. I think that the anesthetic, I think people used to really be concerned about was kind of their major concern was anesthesia, and I don't really think that should be that kind of a concern anymore. Anesthesia has gotten to be extremely safe.
So statistically, I guess what we're interpreting, it is more dangerous to drive on the freeway or drive to the center than it is to have anesthesia, and those statistics have sort of held out and probably are improving. The types of, and so when we divide anesthesia up, I think and plastic surgery is a little bit unique in that our patients are here electively. There's not anything wrong with them, and they're not sick. If they can schedule to do it when they want to, it's not, there's very few plastic surgery emergencies. But there are some, but they're few. So they really have choices of anesthesia. They go from just having local, which for the smaller things is fine, to where they're awake and they have some awareness of what's going on. They probably have some memory or recollection of the procedure in many of these things, to where they're pretty much sleeping the whole time, but they don't necessarily have to be the traditional general anesthesia. You're paralyzed, you're on a respirator, and all that sort of thing. There may be some plastic surgery cases, but for our cases at least, and typically we don't have aesthetic cases. Generally, you don't have to do that, would you say? Yeah,
absolutely. Almost exclusively, none of our patients are paralyzed. That'd be very rare for our patients to need to be paralyzed, so they're breathing on their own. So basically, they're They're deep enough that they are sleeping, so they're not aware, but not so deep that it affects their breathing patterns. Blood pressure, generally speaking, is not that greatly affected with the level of anesthesia that we do. And again, with both yourself and the other surgeons that work in the center, they do a great job of giving local. So generally speaking, I really just need to give enough of the gases or the intravenous anesthetics that we use just to keep the patients asleep, because they're really not feeling anything.
Yeah, that's great. I mean, what we've noticed with Dr. Nielsen and his staff is that really people typically will wake up within, I mean, it depends when I say wake up from a sleep within 30 minutes or so, and it can be walking out within a few minutes after that in many cases, depends on the length of the surgery, of course, but there are other types where, like, as we were talking about, where the person might want to be, and there might be reasons where the surgeon wants the patient awake, especially with the eye plastic surgeons, where they're, checking eyelid function and things like that. Do those differ in any way in sort of safety or effectiveness, or in terms of anesthesia?
There really hasn't been any studies that show that conscious sedation, is what we call it, is actually any safer than the deeper anesthesia.
Yeah, okay. So that, I think that was an important one. What we deal with, so in facial aesthetic surgery, we, as Dr. Nielsen pointed out, we always use, and I think my colleagues that are doing it also use lots of local anesthesia, so that the brain, even though your patients are lightly sleeping and not aware of it, but the brain doesn't sense pain, so the heart rate and the other cardio, the other sort of physiologic functions that would be impacted by experiencing pain don't change. And so we do have indicators of that, and I mean, people do move around a little bit if they're having discomfort, so it tells us when when to give local. Dr. Nielsen can help us with that. And I think that benefit, and along with in those cases, since they're numb, they really don't have to have much of the narcotic medicine, which I think
almost never. I mean, there are certain cases where it's almost impossible to completely numb up a patient, but especially with the facial plastics, very rare that I need to give any narcotic at all.
And that's really the thing with again, we for plastic surgery, I think, in general, we talk about anesthesia side effects and concerns and safety. Nausea and vomiting, or even just nausea, is probably the biggest thing that we face. I don't know if there are actual percentages out there, but there are a number of things that we can do to reduce that side effect. One of them is not using as much narcotics or narcotics at all. Are there other things that we do in our protocols? We don't have a lot of people that complain of nausea.
Very rarely. I mean, I'd say maybe a couple patients a year have any postoperative nausea. And I mean, I think the major two things patients are worried about or concerned about are, besides the safety of the anesthesia, are pain afterwards. And again, because of all the local anesthesia that the surgeons use, it's really, very rarely is that an issue. And because we don't give narcotic, the other thing patients are worried about is postoperative nausea and vomiting. And because narcotics are one of the major 4 risk factors for postoperative nausea and vomiting. And
what are the, sorry to interrupt, but what are the other
three?
Yeah.
The other 3 are, unfortunately, being a female. So if you're a female, that's not much you can do about that.
Yeah.
Being a non-smoker, which is kind of a funny one, and having a history of nausea and vomiting with a previous surgery, or a history of motion sickness. So those are the 4 major risk factors.
So if we have any of or all of those factors, are there things that you and your team do specifically to reduce that?
Yeah, generally speaking, kind of the recommendation of the American Society of Anesthesia is giving one antiemetic, one medicine that prevents nausea or vomiting for every one of those risk factors. So if you have 2 risk factors, you get 2. If you have 3, you get 3.
Okay. So, and are there any newer medicines for anti-nausea effect, or what's your? Let me just put it this way: you and your team, what strategies do you use, or medicines, without getting too technical?
Well, there's a lot of different receptor sites for nausea and vomiting. So I try and hit a different receptor site with every medicine that I give for postoperative nausea. Yeah, again, if you have more risk factors, then I'll try and hit more receptor sites.
And those are given orally or through
given
an IV?
Given IV, except for they're all given IV except for a scopolamine patch, which we put either behind the ear unless it's a facial plastic surgery, and then you can put it on the forearm or inner thigh. You just want it someplace where there's thin skin so it gets absorbed.
Okay. So for us, for those of us that work in outpatient surgical facilities in general, and specifically primarily at the San Francisco Rejuvenation Center, sfsurgerycenter.com is the website if you're interested in looking. They're really a good team of surgeons and anesthesiologists that work with Dr. Nielsen to really improve the care and the comfort and the experience that people have when they're having surgery. We do this every day, and this is a very comfortable space for us, but for most people the idea of having surgery is very foreign, and to try to make the experience as good as the outcomes is an important goal for the SFRC staff, the anesthesia, and the surgeons and the nurses and technicians that work with us. So we're very fortunate to have expert anesthesia care. I would just sort of wrap up by saying, if you have any questions about anesthesia in general, or specific questions that I can answer or I can have Dr. Nielsen address, you're certainly welcome to post them at drmaas.com, our video blog. You can always write us directly. You can send pictures, photos, or even examples or concerns that you might have found in the literature, and we're happy to address those. If you're willing to share those questions or concerns, we can make them public, or we can make them private and just leave it at that. But it's always a pleasure to have your questions answered, and on behalf of Dr. Nielsen and myself, it's our pleasure to help you stay looking your best.
Look forward to meeting you.